tell me or okay. Hello, everyone. Welcome to this session on the basic course Introduction to Digital Healthcare from Access Health Digital 101, Access Health Academy. My name is Arun Kumbat, and this afternoon we are going to go through two themes. One is the fuzzy boundaries for governance, and the other one is about the blurring lines that make for some of the fuzzy lines in governance. So first of all, let me start by saying congratulations, and I would encourage you, each one of you, to see yourself as a pioneer, because India is now walking into the brave new era of healthcare. It's a country of 1.4 billion people. We repeat it often, but we do not understand the scale and the significance. And this really makes this a unique country and a unique healthcare market. And why I say pioneers is because the lessons that are going to come out of this journey that we are making from a broken and disjointed healthcare to a real healthcare continuum is probably going to act as a textbook for many. And you will be leading that as you will be training many people, building capacity for the country to transform to digital health, provide equitable, portable, and accessible healthcare to everyone. So what we are going to do today is basically a process of connecting the dots. One of my favorite professors in behavioral science calls it advanced hindsight. It's a funny term, but it basically means connecting the dots. So as a clinician and as a citizen, I mean, I have done so and you probably do so. We always ask ourselves this question: why must I really bother about governance? We all come from a paradigm where healthcare, really what it meant to us as we were growing up was what happens between a doctor and a patient. And it wasn't any more than that. Yeah. But we all know that things never remain the same. Yeah? They change. And that is called evolution. And guess what? We had a major evolution experience with COVID-19. And who did we look towards most often in this period? We looked at the government most often for answers or guidance or support or provisioning or whatever else that we needed resources. And that is, but government is a very, very limited view of perspective. We often also refer to it as system, administration, management, different loose words that we use. But governance is much bigger than all of that. And government is a very limited perspective of governance. And if you notice that the word governance is basically a verb in the English language, it's not a noun, it's not a dead thing, it's alive, it's dynamic, and it's supposed to perform certain actions, which hopefully we will walk through, and I would be able to give you a little better perspective on governance. So regardless of what we all do in our daily lives as a doctor, as a patient, as a husband, wife, or in the home or in the office as an employee, we all perform at least some kind of role which falls into the category of governance. Yeah. And therefore, you can see that governance impacts human lives in a very profound way, and in something as complex and as impactful as healthcare, it is even more so. Yeah. So, so our view of so let me begin with I mentioned about the perception of healthcare being what happens between the doctor and the patient, right? Most of us have got an expanded view of that thanks to COVID. And we can see how governance touches and impacts lives in such a profound way. Yeah. So it's no longer about just the doctor and the patient. And I'd like to walk you through a few perspectives of this ecosystem, if you like, just to give you an understanding of the various ways to look at it. The first one would be, I mean, I would say, and this is something that as a clinician you would understand very well, if you talk about clinical settings, right? Healthcare As I said, no longer limited to doctor-patient interaction in the clinic. We think of healthcare starting with wellness. Then we talk about people seek healthcare seeking behaviors. We talk about healthcare that is done at home. We talk about the primary healthcare. We talk about secondary and tertiary healthcare. And now we are talking about remote care, right? And remote care can be many ways technology assisted and even in the conventional way, but it's becoming an increasingly important segment of healthcare. And add to this the auxiliary services that we haven't even discussed, which is laboratories, radiology, pharmacy, occupational therapies, nursing, and so on. Yeah. These are all what I would like to call the moving parts of healthcare. And for a system to work together, these moving parts must work together seamlessly. And making that happen is governance. Yeah, the information has to be exchanged seamlessly between this. And I don't have to tell you, as medical professionals, you all have taken an oath that the patient always comes first. That hasn't changed. It never will change in healthcare. And digital healthcare and technology make it possible to have a seamless integration. Now, another way of looking at it is looking at from the ownership structures in healthcare. Now, we talk about the public sector, we talk about the private sector, we talk about the public-private partnerships, and all of that. And I think a recent experience has made it absolutely there is no argument that all these sectors need to function seamlessly together, really, and we should stop discriminating between these three entities or these three sectors, so that healthcare can be provided in a very, very seamless fashion. Yeah. Another way to look at it is perhaps from the perspective of jurisdiction. I mean, there is the state government, there is the central government, and then there are powers that are devolved between them through the Schedule 7 of the Constitution. And healthcare is a state subject. We've all experienced the central government first having provided centrally assisted through COVID, and then the states wanted, because it's a state subject, they wanted to take control of the provision in COVID. So that also adds to the level of complexity, and which is why we need to look at governance very, very carefully and understand what governance is all about. Yeah. Again, all of these need to work seamlessly together. Yet another perspective to look at all of this is a role-based perspective. Typically, you could see three roles in healthcare. There is the patient, the provider, and the payer. Now, each of these particularly the provider segment encompasses a lot of different moving parts or players, which I already discussed in the clinical settings theme. Yeah, and therefore you can see that all of these work with different perspectives. They have different motivations. There are different drivers, and yet if we are talking about healthcare being a continuum, they must work together seamlessly. And for us to be able to have a healthcare continuum in the real sense, and the ability to serve the need of each other, there's an interdependent ecosystem. Yeah, so there are trust issues to be addressed, and here's where digital health can play an extremely important role, and so can medtech. So, given all the diversity that I have discussed, it isn't very surprising that there are fuzzy boundaries that need to be overcome in healthcare for healthcare to be able to successfully fulfill its aim of providing universal healthcare. Now, when we talk about universal healthcare, we all agree that the patient must come first, and the sustainable development framework, sustainable development goal number 3 is universal healthcare. India adopted it as a policy in 2017, and subsequently a lot of steps have been taken to make that a reality. I would request my team to play a little video that we have, which will give you the dimensions of why we need universal healthcare actually. Can we have the video, please?
In 2012, 5.5 crore helpless citizens in India were forced into poverty because of exorbitant healthcare-related expenses. Out of these, 3.5 crore fell below poverty line due to spending on medicines alone. India's healthcare sector is facing a major crisis, and the poorest of the poor are bearing the brunt. However, the ambitious National Health Policy 2017 brings with it the promise of a real and meaningful transformation in the healthcare landscape. The Government of India is now committed to fast-tracking initiatives aimed at ensuring health coverage for all. Given the scale and scope of this massive undertaking, it is a dream that can only be realized through the intervention of technology in the healthcare sector. Although it is commonly perceived that India is largely digitally illiterate, the facts paint a different picture. Today, we have one of the fastest growing online communities in the world. The spread of mobile technology and radically declining costs of data is transforming the way people connect, transact, and interact. Combine this with the grand success of Ayushman Bharat's healthcare coverage for the poor. The stage is set for the great Indian digital healthcare revolution. Imagine a healthcare system driven by digital personal health records, where information technology is used to leverage data, thereby enabling access to quality healthcare to anyone, anytime, anywhere. Where a national digital health ecosystem nurtures collaboration, co-optation, and interoperability among all stakeholders. The great Indian digital healthcare revolution is long overdue. If we can imagine it, we can make it happen.
देश के 50 करोड़ से ज्यादा भाई बहनों को 5 लाख रुपए तक का हेल्थ एश्योरेंस देने वाली ये दुनिया की अपनी तरह की सबसे बड़ी योजना है। पूरी दुनिया में सरकारी पैसे से इतनी बड़ी योजना किसी भी देश में दुनिया में नहीं चल रही। पूरा यूरोपियन यूनियन उसकी जितनी आबादी है उतने लोगों को भारत में ये आयुष्मान भारत योजना का लाभ मिलने वाला है।
So as large as Ayushman Bharat or PMJAY as may be, it's still a part of the healthcare ecosystem. And there's much more to healthcare than just that, right? So two things are very clear when we talk about universal healthcare. The patient must always come first. That seems to be a shared value across provider, payer, and the patient, of course. Yeah. And the second thing is that the importance of the financial lever. I think Dr. Pankaj Gupta in his earlier sessions has talked about the financial lever, because no matter what your role, no matter what you do within healthcare, you need to be paid quickly, you need to be paid transparently, you need to keep the wheels turning, right? And to use resources efficiently. And that's going to come from the payer. So clearly what I want to bring out here is that there are information needs across all the segments of healthcare and all the players of healthcare. And that is the only thing that can make governance possible, can make the healthcare continuum to work seamlessly together. So there is a need for visibility across all the stakeholders. There's a need for interoperability. And there's a need for inclusivity in how we approach governance and how we approach digital health and how we approach the healthcare continuum. So when I say that, I mean, I say that healthcare really hasn't been operating in a vacuum. Healthcare has been around hundreds of years before we are having this discussion. So there are existing systems and there are new systems that are going to be built, right? So if we just go a little higher in this document, can we just go a little towards the beginning of the document? You will see, up, yeah. So you will see what I'm talking about in terms of the diversity and the fragmented nature of healthcare in India existing as it is. Everything operates in silos. You can see that there are 900,000 doctors in India. Now, that's a massive number by any standards in the world, but it's still not enough. And let me be a little cheeky and suggest to you that that 900K numbers, we say that as an approximation. No one has a real idea about the exact number, where they are, what they do, what their qualifications are, where they are located. Are they still in India? Are they alive? Are they deceased? So these are guesstimates. Now, that's not a great testimony for the quality of governance so far, right? Then we say that there are 50% of them who are in the large metros. Now, uh, we also know that 70% of the population lives in non-metro areas in India. So that's a huge skewness. How do you address the healthcare of the remaining 70%? And again, coming back to COVID, we have seen what happened in the massive second wave that the cities fought with. That wave is now reaching the rural areas. So it's actually now hitting the 70% that we are supposed to address. How do we address that? That's also a governance challenge, right? 40% of them, of these are in tier one and tier two cities. 10% are in the semi-urban and rural areas. Can you picture that in your mind? What a fragmented situation there is. Yeah, and the rural India, or let's say the bulk of Indians, are really left in the lurch. Yeah, there is only 5,000 seats in medical college for specialist doctors every year. 1.4 billion, 5,000 specialists, 900,000 doctors. Not a very pretty picture, is it? Yeah. So, and if you look at the majority of doctors, they go into primary and secondary care. Again, there is a vast amount of unserved population. Historically, we have kind of, the governance has been focused around women and child health. And that focus still remains kind of a legacy. Whereas the disease burden, as you know, as practicing doctors, has shifted to the non-communicable or lifestyle diseases, as we call them, to a great deal. Of course, mother in absolute numbers, mother and child health is still important. Infectious diseases are still important, but the burden has definitely shifted. Now, the governance needs to account for that reality. So I'm trying to underline the fact that governance in near real time, based on near real time data, is absolutely key for the equity, accessibility, and quality of healthcare that the citizen gets. Now, if you look at other parameters, there is 1 bed to 1,000 per thousand in the population. We need at least 3 times of that. Yeah, which is what the WHO recommends. It actually recommends 3.3, right? Now, 5% of these are greater than 150 bed facilities, or the ones that we loosely call secondary and tertiary hospitals, largely focused in urban metro areas or tier 1, tier 2 cities. And we saw, unfortunately, those are the ones that we talk about most. And there is a vast amount of discomfort to a large numbers of population that needs to actually travel to these places to get some attention, some medical attention at great expense out of their pocket. You just saw the video, the consequence of that. Then about 5% are facilities that are between 50 to 150 beds. And these are facilities, again, concentrated in the tier 1 and tier 2 facilities. Whereas 90% of the beds are in small clinics and medium-sized nursing homes around the country, less than 50 beds, sometimes even just a doctor in a clinic for a large number. So you get the picture. The healthcare sector is rather fragmented. Now let's talk about the auxiliary services that healthcare really depends upon. You've got over 100,000 labs of all descriptions, out of which I would say about there are 4 or 5 major organized brands operating. You and I know them very well, but then there's a large amount of service being provided by the let's say the non-corporate labs, the standalone labs. And there is a need for information to flow from and to them besides standardization and quality. 60% of these labs are small and medium-sized labs. As I said, 20%, less than 20% are organized labs. 20% are hospital-based labs, which is also a very significant chunk. And only about 1% of these labs are accredited by the NABL, which is the certifying body for laboratory standards. So you can imagine the kind of disparity and the diversity that exists in the healthcare sector in India, be it in terms of people, be it in terms of beds, facilities, auxiliary services. Uh, the other significant part of healthcare is the drugs and pharmaceuticals. There are 65,000 stockists in the country and about almost 1 million retail pharmacies. Yeah. Now, 6% of the total sales come from from the organized pharmacies that we talk about, the ones that are well-known brands, which I'm not going to touch upon here. Another 6% probably comes from hospital pharmacies. That leaves about 88% coming through the retail pharmacies. Again, there is no control over the drugs in terms of quality, in terms of spurious drugs, in terms of antibiotics being dispensed without prescriptions. I know of cases where the same brand name had two different active ingredients in two different states. Now, when we talk about portable healthcare and mobility, I mean, there is a potential for a loss of life if that happens. If someone goes and buys a brand of a drug with a different active ingredient in a different state, there is a potential to lose a human life or at least significantly impair the quality of their lives. Now, these are all governance issues, and which is what I meant when I talked about the fuzzy boundaries of governance. We need to address all of that. Hopefully, I've been able to give you an understanding of why, as a healthcare professional, we cannot say governance is not my business. Now, wherever you are in healthcare, whichever role you're playing, whichever segment you operate in, whichever entity that you work for, even if you're a governance is everyone's business. I mean, if we are to provide quality and accessible healthcare to everyone in India. So governance's job is so all of us have heard the cliche that the diversity of India, and I hope the numbers that I presented to you gave you an idea of what this diversity is all about. There is not only diversity, there is also a lot of disparity between all these facilities, and the job of governance is to stitch together this whole diverse and disparate ecosystem so that healthcare in healthcare, this is really, really important because it's a matter of human lives. This is not about money or a transaction or something as ordinary as that. We're talking about human lives and the quality of human lives. And so the challenge is how to make a diverse and interdependent ecosystem to work together. Clearly, we are all parts of a healthcare system, but we can't. Can the parts really disregard the whole in this case? We're talking about human lives here. So as a part of our realization of this, about a few months ago, we did an exercise because as a think tank, we had developed a lot of design and did some design thinking for solving this challenge of disparity and diversity in healthcare. And so we've done a payer-side working group to unify the payers to come to a common standard so that information and could flow freely between them and they could work seamlessly. So we did a similar exercise from November to March, November 20 to March 21, 6 months. We had about 40 different consultation sessions with over 200 professionals, healthcare professionals all across the country. And we called it the Provider Working Group, right? And we were able to evolve a consensus on how to address this challenge of diversity, disparity, and fragmentation so that we could overcome these fuzzy boundaries that we are talking about and make the healthcare continuum really function. I will be sending you out a copy of this Provider Working Group report, and I would urge you to go through this report in whatever kind of detail you can go, particularly the prologue that is there. It's very easy to understand. It's non-technical, and the conclusion. And those of you have those of you who have can go through a little more technical material, the body of the material really contains the building blocks that can make this possible. So what we're suggesting is that we need to fold in the existing systems, we need to fold in the new systems that come in, and there are solutions for all of that using something that we call e-objects. We have also recommended building a healthcare facility, as I talked about the 900K doctors and the disparity in distribution. We have talked about building a drug index. I gave you an example of what can happen by not having a drug index. We have talked about telemedicine and how it can be deployed to provide equitable, and accessible healthcare to people right at their doorstep in rural India, so that we are never inadequate in terms of providing healthcare, and our healthcare system can do the best that it really can. I must end this on a congratulatory note, because all of you have provided a wonderful, wonderful frontline service in the times of COVID. Yeah, and I also talked about inclusivity, which is also talked about in that report. It's very important for a country like India, which has such a fragmented healthcare, such a diverse and disparate healthcare system, to take a very inclusive approach to stitching all of this together rather than an exclusive approach. It's all discussed in the report. Please do read it, and I'm sure you will come out much richer in terms of your understanding of the healthcare system in India. And if there are any questions, I'm happy to take them now. Yeah, anyone? Or shall I just get to the second part of, better still, I would like to invite Dr. Pankaj to maybe add something with his experience. I may have left something out.
Pretty much covered, Arun. Actually, you've done a wonderful job at covering all the fragmentation that is out there, the diversity as we call it, and I think we can talk a little bit about the fuzzy boundaries in terms of the reporting hierarchies, and how many of the things are completely left out like an oversight. Probably when the healthcare system was evolving, the governance sort of lost track of the evolving fringes, and also some of the very core components that got added later. So maybe that's an area where we should sort of shed a little light, and most of it is, I think, pretty well covered. We can invite questions. People should read up more. These are things that are not really talked about in most of the forums, most of the public health textbooks. But these are hard data which we cannot ignore.
Absolutely. Yeah. So in the second part of what I'm going to talk about is the lines are blurring. I hope to give you an insight into why there are fuzzy boundaries. But if there are questions before that, I'd be happy to take them. Or shall I, if everyone agrees, then I can get to the second part, and then we can leave the questions for later. Is that okay?
Maybe what I can do is just to sort of stimulate people's thinking, give an example of fuzzy boundary. So one example, my favorite example is radio diagnosis. This is an area where it really doesn't come under any authority, only for the radiology purposes. So whether the dose and the radiation is within the limits, safe limits, and all that. There is a BARC, that Bhabha Atomic Research Center. So they have sort of a badge that every radiologist is supposed to wear, and the inspector will come and inspect it. And they are sort of going to take care of how much of radiation is there in the facility. Beyond that, there is really no regulation on the radiology centers. How many are there? Who? What are they doing? Whether there's a patient safety aspect built into it or not. What are the services being rendered? There is really no registry for that. There is no single source of truth for that. So, that's just a one example of the fuzzy boundaries that, Arun was alluding to. And then there are a couple of other things that, you can read up, but, the more important thing is that uh, you know the healthcare has sort of evolved over time. Another example is the drugs. So our more drugs are chemicals at the end of the day, so they are managed and controlled largely by the Ministry of Chemicals and Fertilizers, and they have a structure to sort of regulate them as a drug from a Ministry of Health. But the entire structure of regulation from the two ministries, if you sort of look at both from two different angles, is quite fuzzy in nature. That leads us to the next topic about lines are beginning to blur, and I'll let Arun cover that.
Yeah, thank you, Pankaj. And in this segment, I'm hoping to give an understanding of why the fuzzy areas exist at all. There's any number of fuzzy areas that we can talk about, and it's all discussed in the reports and our blog that we are talking about. But let me try to give you an understanding by talking about the lines that are blurring on why these fuzzy areas exist at all in the first place, right? So in the previous segment, we talked about understanding the dynamics of the healthcare continuum. We talked about the interdependence and the moving parts that need to function together, and addressing their individual interests so that they could work together. Now, in this segment, we would try to delve deeper into what we call the fuzzy boundaries and try to understand why they happen at all. Yeah? We can talk about a number of fuzzy boundaries. Pankaj talked about a couple of them in terms of drugs being seen. Drugs being seen as a chemical. And I can, given the 20 years that I've spent in pharmaceuticals, I can do a half-an-hour lecture on that. Yeah, but it's not necessary. I mean, the fact is that there are fuzzy boundaries in the governance. Yeah. So, what causes these blurring lines and overlaps between disciplines? What causes these things is that the way I like to see it is that pretty much all the fundamental science that needed to be developed has been developed. I mean, we are not going to rediscover gravity again. We're not going to discover friction again. We are not going to discover the laws of motion again, right? All that has been done. So the new innovation that is happening on how to leverage what we already know. And most of it is happening in areas that converges more than one or two disciplines. And most of our regulatory framework was written in the 1940s. For example, the Drugs and Cosmetics Act is a product of the 1940s. And we have walked a long distance in terms of innovation, in terms of where we have come from the 1940s. And yet the Drugs and Cosmetics Act was amended in February 2020 to or notify that all the devices will be seen as drugs. But is that really adequate? Now, let me give you the analogy of a mobile phone. Right, a mobile phone is a perfect analogy to of what I'm talking about in terms of innovation happening in areas of convergence. The innovation is all about what we are beginning to know. So our approach to governance, as I told you, has already discussed in the last segment, and we're now discussing innovation. There is a time lag. I mean, that the governance has not kept pace or has not been proactive in terms of or being cognizant of the innovation that is happening at the cutting edges of innovation. And therefore, governance has tend to lag behind in time. And the Drugs and Cosmetics Act is a fairly good example of that. Yeah? So governance and legislation or regulation have stayed behind, and innovation has kind of grown in exponential terms. And I was using the analogy of a mobile phone. Now, if you look at the mobile phone, it was just a phone not so long ago. But today, a mobile phone is a camera, it's a torch, it's a recorder, it's a reading device like Kindle is, it's a publishing tool, it's a television by itself, it's a newspaper by itself, it's a computer on its own. Most of us communicate through WhatsApp. We very seldom send emails unless there is something specific to formally to communicate. It works as a navigational aid, it works as a medical device, and so on and so forth. Yeah. This was never visualized. This was never visualized in the 1940s or even as late as the 1980s. Yeah. And the world has changed, and therefore the lines are beginning to blur, right? There is innovation happening on the converging areas of science, of different disciplines, of biology and of physics and of electronics and bioinformatics and genomics. So there's a lot of innovation happening on converging areas, and laws, unless our approach to governance and unless our approach to regulation changes, we would still have these fuzzy areas. So I hope to have given you an understanding of why the fuzzy areas get created. Yeah. Let's discuss some aspects of, so as I talked about the mobile phone, you have innovation in terms of wearables. I mean, you have these watches from Apple or Samsung or Goki, which do multiple amount of things. You have Netflix, which has brought the cinema right into your mobile phone. I mean, and you have Amazon, where you don't need to step out of your home and you can shop everything that you want. You access information through your mobile phone. Most of us, at least I, have discontinued buying newspapers and watching television, right? As I said, innovation has changed everything, and we are going to discuss some aspects of this today. So what I'm trying to basically underline is that there is a disconnect that happens between innovation and regulation. So if the Drugs and, as I said, the Drugs and Cosmetics Act was amended through a notification in February 2020, and it recognized that all medical devices will be treated as drugs. But so far, only 37 categories of devices have been recognized, whereas the reality in terms of innovation is very different. Innovations are continuing to break boundaries, and therefore more questions are being raised than answers answers being given by the kind of regulation, by the kind of approach we have towards regulation. So you have devices and software combinations, you have bolt-on devices which make your mobile phone do a number of things, you have ingestibles, which mean you can swallow a device and it can be used for imaging or delivering drug to a certain part of your body. You have implantables, which can get implanted in your body and can continue to provide data and improve the quality of care. You have wearables, I already talked about. There are jackets which you can wear in intensive care and which will take care of a number of parameters and transmit the data to the network, which will then allow your doctor to have a continuous view on your health. There are drug device and software combinations and all their permutations and combinations possible, right? And then you have the payer, provider, patient interests, which are basically around safety and quality in an area that is exploding with creativity. Yeah. So all this innovation allows you the opportunity to manage disease, which insurance is very interested in. Dr. Pankaj has already talked about the financial lever and the public health concern that governance has and every one of us has to see that a large population is not rendered unhealthy, remains healthy and productive, and has a good experience of life. Yeah. But let me also share that the regulatory challenges are not just unique to India. I mean, every healthcare system in the world has had the same challenges. The question is that they've responded differently. I mean, if you look at the US FDA, right, they are one of the most proactive regulatory regimes because a lot of innovation happens in that geography and in Europe, and it's a large market, so most of the innovation in other geographies tends to find its way into the US market. Yeah. Let's look at some examples, and maybe I'll invite Dr. Pankaj a little later to come in and talk about this in even more depth, but let me give you some very, very, very basic examples of what happens, yeah, and how things are evolving in the healthcare space and how regulatory regimes need to catch up. Take the example of a company called Becton Dickinson. Becton Dickinson is in a variety of ordinary devices, including syringes and so on and so forth. But it also does reagents, has acquired 23 companies over the last few years, and its business is in very diverse areas. Now that they've acquired these businesses, they definitely will, as all businesses do, explore the overlaps between these two businesses. I mean, you acquire a company first when you see an interesting overlap in the first place, but then you want to exploit it and you want to take it to the hilt, right? So there is more convergence being created. There is more innovation happening, and there is a stronger drive to serve patient needs. I mean, they're able to serve patient needs in so many different innovative ways. If you look at a company called Verily, which is basically Google or Alphabet's healthcare IT, or that's a very primitive term. Healthcare IT is a very primitive term, but it's this digital health operations. Now, it kind of straddles innovation between genomics, bioinformatics, EMR, Internet of Things, and robotics in surgery. And of course, there is always the human element. So we're talking about a space where innovation is happening at a pace which was never imagined in human history. Now, if you look at more simpler examples, there is Fitbit, which is a wearable device like a watch, which will monitor several parameters. Samsung has some of those devices. If you look closer home in India, there is a company called Goki that provides a wearable which monitors 4 parameters, which is your SpO2 and your heart rate and your blood pressure and stuff like that. There is recently I came across a company called CarePlix. Now, when the whole world in the COVID era was fighting a shortage of devices to measure SpO2 and your heart rate, they went ahead and created an app where your smartphone could double up to as a device to measure SpO2 and your heart rate. You just had to put your finger on the camera and turn on the app, and voila, you had your SpO2 readings. So, I mean, people couldn't find pulse oximeters at 3,000 rupees, and here was a freely downloadable app that could be used on your mobile phone and solve a problem in such a huge crisis. Now, if we talk about a company like Roche, which is a European company based out of Switzerland, but it's a global company and pretty much a household name today because it functions with a number of devices in a number of therapeutic areas, which are too many to count on the fingers of 2 hands even. And these could range from something as simple as diabetes to something as sophisticated as oncology, applying genomics to diabetes care and everything else that they do. So there is more convergence happening. There's more innovations happening, allows disease management, gets the payer again interested in disease management. So there's a convergence of not only technologies and devices, there's also a convergence of interests happening from the payer and the provider and the device companies and the payer. So in this segment, if you look closer home, there's a company called Beto. Incidentally, they're a part of our startup social entrepreneurship accelerator program. Now, they have a bolt-on glucometer. You add a device to the phone, it becomes a glucometer, and it can check your sugar data, it can issue alerts, it can issue notifications and do analytics, warn your doctor if something is completely out of whack, and your doctor can then make an intervention based on the data that he receives. None of this was visualized in the Drugs and Cosmetics Act of 1940. Yeah. There is another company in our social entrepreneurship accelerator called Neurosynaptics. Now, Neurosynaptics produces devices, multi-purpose devices, which is a single device, very, very, very useful in remote care, which can measure multiple vitals in real time, complement it with telemedicine, and make remote care possible in the remote areas of India. None of this was visualized earlier. Now, maybe at this point, I would like to invite
Yeah. Arun's video seems to be frozen. I'll try to sort of cite an example in the meanwhile. So Roche acquired My Sugar, which is an application. It's a mobile app you can download to manage your sugar. And we all know that Roche has a diabetes portfolio, pretty large, and it controls a very large segment of the diabetes market. Now, when you combine all of this, if you were to buy a Roche pen from any of the Roche sort of dealers, and so what Roche does is, uh, along with its insulin pen, it also gives you the My Sugar app. So you are controlling your dosage, and the schedule, and also sort of many other things, in terms of a full disease management model. Now, from a regulatory perspective, if you look at it, is it a mobile device? Is it a medical device? Is it a software? Is it a drug? Is it a, what is it? I mean, is it a program? So, if from a regulatory perspective, you have to regulate it and put a regulation around it, where do you draw the boundary? And this is exactly where we are saying the lines are blurring. So lines are blurring between a device, a drug, and software as broad categories, but also devices which are not really medical devices. Mobile devices and internet devices are coming into the picture. So you are having, social media, mobile, artificial intelligence, Internet of Things, all getting bundled into medical devices, and you have medical devices getting bundled into drugs. So where do you draw the line? And this is becoming a huge issue for all regulatory sort of bodies all over the world. So Roche is a classic case where it sells the full diabetes platform, starting from the My Sugar app. Uh, it gives you a mobile app which can connect to the point of care devices for monitoring your blood sugar, and it gives you the blood sugar control drugs. So, and it sells the entire thing as a package. So you get registered in a disease management model, and it very closely monitors the patient. It makes sure that your HbA1c levels remain low. I don't think they've launched it yet in India, but in many other countries, it is a grand success. Now that once it is launched in India, I'm pretty sure the regulatory framework in India will have a challenge to figure out: is it a drug? Is it a device? Is it a mobile phone? Is it a software? What is it? Where do you draw the line? So that's an example. Arun, back to Arun, and Arun, you can carry it forward.
Yeah, Dr. Pankaj is clearly, at the cutting edge of what is happening in both from a clinical perspective as from a technology perspective. So very useful to have heard that, Pankaj. Thank you. And so as you can see, there is more and more intelligence being built into devices. What was device was once a passive word, it no longer is. I mean, it's a very active participant in the healthcare ecosystem. So you have wearables, you have implants, you have ingestibles, and as more and more disciplines converge, you have solutions coming out of virtual reality, augmented reality, and all of that. And clearly, as Dr. Pankaj explained, I mean, there are dilemmas that need to be addressed. And what we can learn is that from the US experience and US FDA that I referred to was that all this is impossible to address without a single body having an oversight for the purpose of regulating, monitoring, and measuring the efficacy of a particular device or drug or whatever else has been introduced in the market. And then also have a post-market oversight on how it's performing. Is it doing well? Is it still relevant? Not relevant? Should it be taken off the market? Or does it need to change? As healthcare is an evolving field, as we all know here, technologists tend to understand that a little bit less than us in terms of things keep changing in healthcare. Yeah. And so it's impossible to address all of this without having a single regulator. And that regulator within itself must fold in various areas of specialization and domain experts who can actually look proactively at the future and uh, help regulation keep pace with innovation. Yeah. So if you look at the US FDA, now there are cases of software being used as a medical device. They have recognized a lot of device softwares as medical devices. There are softwares that are integrated into devices, and there is software that's used to manufacture and maintain devices. So these are the three major areas and how they perceive technology interventions in healthcare. And there is also the category of devices when, as a drug, when it's ingested. Uh, so again, it's all about keeping the patient first, as we share that value of keeping the patient first. All innovation is centered around keeping the patient first and making sure that public health benefits from it. There is a body called ONC, which is the Office of the National Coordinator. Now, they do even go beyond what we have just discussed, right? And they look at the planning, adoption of infrastructure, platforms, initiatives, and it's their job to advise the government and on IT infrastructure as a large to support healthcare well in anticipation of what is coming through innovation. Yeah. So we need to develop a similar far-sighted approach in India, and to make sure that we provide for the future a clear pathway, clear demarcations of regulation is going to emerge, and related expertise is going to be harnessed. And given our size, we have talked about the diversity, we have talked about the disparity, we have talked about 1.4 billion people. Uh, and COVID has also underlined the need for resilience in your own systems. I mean, and it can only come from a lot of research, it can come from a lot of development, innovation that has to happen, but you need a very strong and clear, proactive, forward-looking regulatory regime for that. And as a country, we can only ignore that need at our own cost and in our own loss. So with that, I'd like to conclude my remarks. Is there anything you'd like to add, Pankaj?
Yeah, I'll just like to add one more example, just like I sort of touched upon the pharmaceutical example. Payer example will be sort of a good rounding off to what you have just said. So, there is in a life insurance company called John Hancock in the US. What they have done is, until very recently, they used to do a plain vanilla life insurance. But then their board realized that, after giving a life insurance coverage, they are sitting and twiddling their thumbs until a person actually dies or the policy matures. But that's not really a good model to have. So they said, if we can keep the person alive and healthier longer, then we may not have to pay the the whatever is the maturity benefits until until maybe a year later, or 2 years later, or whatever number of years that we can keep him alive longer. So they said, so instead of sitting and twiddling our thumbs, we should turn the business on its head, and they got into disease management. So it's no longer a life insurance company, it is a disease management company now. So they actively engage with their members to keep them healthier longer, keep them alive longer, so that they don't have to pay until a couple of years more. So even if they can keep the person alive for one more year, they've delayed the payment for another year. And that's a huge benefit to a life insurance company. And that's one more year of life to a person. And if the interventions are done much earlier in life, then it is many more years of life. And to do disease management, they had to shift their model. They had to sort of come into disease management, which includes devices, it includes drugs, it includes interventions through call centers, it involves so many other things. So, now you will say, where are the lines blurring? Well, the lines are blurring from the health insurance all the way down to drugs and devices and interventions that are, so you're basically getting into the life of the person, and you are becoming a friend of the person. You're going to call that person every day and say, I'm there for you. Now that's like, trying to know your customer, trying to know your patient more than what any neighbor of that person knows, or maybe even the family member. So that is getting very, very personal. So that's a lot of privacy data that you are privy to. And that brings in the aspects of privacy and security of that data, because it's very, very private data to that person. But you have to have that data to keep that person healthier longer and to be able to live longer. So I can go on, but I just wanted to give you a sense of how health insurance, life insurance, disease management, and then a whole lot of devices and drugs and privacy and security are all bundling together, and then a whole new paradigm is emerging.
Thank you, Pankaj. And that sort of gives a very well-rounded picture of governance to end with. And would be happy to take questions if there are any.
There was a question earlier from somebody called Lakshmi Kant about how would you take the healthcare where the internet access and the usage is not there. Now, that is something maybe we can pick up. Arun, would you want to reflect on that?
Let's go ahead. I think the long and short, the short point is that things are changing. Yeah. Just a few years ago, we did not imagine, that telephony. I remember when in the 80s, when I bought my first mobile phone. I mean, before that, we used to buy phones and wait, make an application, wait for 12 years to get a phone, right? Things have changed. Accessibility is, the TikTok videos that you see posted on WhatsApp are a great example of people creating TikTok videos in areas that you can't imagine. Yeah, so we're getting there. Things are improving. There is 4G, now there's 5G coming on. The prices of devices are plummeting again. So connectivity is getting better and getting better very rapidly. Yeah. So, Pankaj, would you like to add to that?
Yeah, I'll just quote some hard numbers. So there are about 1 billion mobile phones in India now. Out of that 1 billion mobile phones, about 90% of the market is Android phones. Um, and out of all the smartphones that are out there, the Android phones, that is, uh, 60% of those are high end smartphones. So these are like which can take apps and do a whole lot of things. So the entire market is shifting towards a model where it'll be mobile driven. Gone are the days when you would do it on a laptop or a desktop. So connectivity for a mobile is already good enough. So it is going to be mobile platforms, tablets, which are going to sort of rule the world. And I think connectivity is enough for that. Even if you have a slower connection, your mobile app will usually work.
Yeah, there's hardly a panchayat in India where you don't have connectivity. I don't think there is any.
Yeah, true.
And it's better than going to the city to access healthcare, right? to go to your panchayat.
True.
So accessibility is not the issue. I mean, the convenience, maybe it's not as convenient as you'd like it to be, but it's accessible.
True. Absolutely true. Okay.
Yeah. So shall we close this? Shall we call the session to a close, or are there any other questions that we need to address? But I would like to encourage you to write in. I mean, you have our email IDs, you have phone numbers available. If you think of questions later, or if you think that your question is a bit long winded, or you want to have a more informal discussion, please feel free to write in by email. Please feel free to call us if you will. And then we are just happy, we're only too happy to hear from you. Yeah.
Arun, we have one more point to answer. uh, Sorry, the questions we have is whether the cost of the healthcare increase. Do you think with the digitization of the health?
So, if I understand it correctly, it's about whether the cost of healthcare will increase with
With
digitization of
increase.
health.
Yes.
Short
Yes.
answer, no. Short answer, no. Yeah, because uh, the cost of access to healthcare is a very significant part of healthcare, right? And then there is the cost of drugs and wrong medication, stuff like that. So you're removing, I mean, with digital health, the cost of access is brought down very significantly. Let me illustrate this point by a simple example now. We talked about patients in the village having to access a secondary facility or go travel somewhere. Now, typically, a rural patient, when he has to access medical care, has to travel maybe half a day somewhere, spend 500 or 600 rupees to get there, pay the doctor's fee, and then lose a day's wages for something like a simple consultation. You remove all of that. He doesn't have to travel to the city, sleep on the footpaths, eat outside, spend on travel, and then remember that the patient doesn't travel alone, right? So we're talking about making healthcare a lot more affordable. We're talking about a third party being able to pay for your healthcare. Let's not forget that, whether it's Ayushman Bharat or private insurance or anything else that will come in future. And we're talking here about reducing the out-of-pocket expense for the patient, like you saw on the video. Yeah. So actually, digital technologies are going to make healthcare cheaper, more accessible, portable, convenient, rather than make it more expensive.
Just to add to that, the technology as it matures and the new models of technology come in. One example being moving from the monolithic technology of the yesteryears to digital technology microservices. The amount of investment that you require to run a microservices is much smaller than a monolith, including development and maintenance. Some people say it is 1/10 because it has a much smaller footprint. The amount of code that you have to write is much smaller. The maintenance is much easier. You don't have to bring down the system again and again to maintain pieces of code. So uptime is higher. You can put it on the cloud, though your footprint is going to be small. The amount of space it consumes on the cloud is much smaller. So all plus, the total cost comes down significantly.
Let's not forget that it took 3 times the capital investment in monoliths to train people to make the system usable. That is gone. Now, which of us remembers having been trained to use WhatsApp or Netflix? Did anyone spend any money getting trained on how to use WhatsApp or Netflix? That's exactly what is going to happen to healthcare with digital health. So we're talking about the costs coming significantly down. Not just down, but significantly down. I hope that gives you some insight into the coming change in terms of costs.
So I think we can wind up. Komal, is that okay now?
We just looking forward to any questions or feedback on this today's session because we have covered 4 topics during the last week and a half. So, any comments, questions? We'll wait for another minute and then we'll
Okay.
go over the closing session. Thank you, Lakshmikant, for your feedback. We really look forward to an interactive session. And if more of you join us and give us your feedback, we'll be more happy to share our experience with all of you. Okay, I think there is no more questions, Dr. Pankaj and Arun. Thank you so much for today's session, and I think we are good to close for today. And the next session we'll have it on Monday from 3 to 5. So looking forward to see you all for that session.
Thank you, everyone. Have a phenomenal weekend.
Everyone.
Yeah, look forward to seeing you next week.
Thank you.
Thank you.
Bye.